Good evening, and I know you all are exhausted, so I will not take much of your time because sir has given an exhaustive review of what is diabetes and how it is diagnosed. What I'm going to tell is what we generally do, and your opinions. It was nice to hear that this kind of things are being treated. I have no knowledge about your form of medicine, but then it was nice to learn that it is being treated like this. Okay, so as we all know, the definition of diabetes is nothing but an abnormal glucose metabolism leading to hyperglycemia. In simple terms, blood sugars are elevated. And why do we want to know this? Because we are the diabetes capital nowadays. From age 20 to 79, the maximum number of adults with diabetes are found in our country. And that is the most productive years of our life, which are suffering from a disease which is chronic, ongoing. It can be slowed down. Whether it can be cured or not is a question, and the comorbidities and the mortality it is bringing about, right? So how do we diagnose diabetes? Till now sir had spoken about how you diagnose a pre-diabetic. So in diabetes, to diagnose diabetes, you should have a fasting blood sugar of more than 126 milligram per deciliter or an HbA1c value of more than 6.5 and postprandial value of 200 milligram per deciliter. Supposedly, if it is not a postprandial value, somebody with a symptom of hyperglycemia in the form of a polyuria or landing into a complication like sepsis or decay or a hyperosmolar state, then you need not even wait for a fasting blood sugar or an HbA1c. Any complication of diabetes along with a blood sugar more than 200, then you are looking at diabetes. Now, what is important is which investigation is better if we can diagnose with all. For an acute complication, it is better to go in for a fasting blood sugar level, which is more than 126. The advantage of this method is it is an easy test to be done. Almost all laboratories will be able to provide it. But the problem with the test is the pre-analytical handling of the sample. That is, if the sample is not immediately processed, it has to be kept in ice. Otherwise, hemolysis occurs and the enzymes within the RBC will metabolize it faster and you might have a fallaciously wrong value. So that is the importance of knowing that we can do a blood sugar fasting easily, but the problems with it. And for a chronic state, that is the person is having hyperglycemia for a very long time, that you can obviously identify by an HbA1c. There is no such problem like you asking a person to come fasting to get the sample. No relation with meal, no relation with an acute illness, no relation with stress. However, there are certain conditions in which HbA1c values are not used to diagnose. Here we have written on top, non-pregnant individuals. It means in pregnancy, you do not want to diagnose a diabetes by HbA1c. Why so? HbA1c is nothing but a glycated hemoglobin. In pregnancy, there is a rapid turnover of the RBC, and the RBC is the carrier of hemoglobin. So if the hemoglobin is turning over rapidly, so the value which you are getting probably is not the correct indicator of sugar. So that is why in pregnancy, it is generally for a fasting blood sugar levels or an OGTT value that will help us to diagnose. Otherwise, HbA1c is good, and certain disorders, for example, hemoglobinopathies, and in iron deficiency anemia, which is a very common thing found in our country. In such states, you have a fallaciously low value. So the moment you treat iron deficiency anemia with iron, the value will rise. So in such a scenario, a fasting blood sugar level is far better as compared to an HbA1c. And even certain hemoglobin variants also, and the test, point of care, it is not good for a point of care test to be used. It is better that we send to a lab. So that is the only this thing that we will say ki in diagnosis of diabetes, both blood sugar values are good and HbA1c, but with the idea in mind that there are caveats to the use of both. Okay. Then we have all known what are the symptoms. Most common is fatigue. Sometimes people just complain that they are tired, or weight loss, and as you all were discussing, the same symptoms they will come, but should we wait for the symptoms, or whom do you think are at risk? For that, we can have a questionnaire. This is provided by the American Diabetic Association. This you have to mark the answer and you have to calculate the score. Anything more than 5 requires you to be assessed for diabetes. So the first question is, how old are you? So the age less than 40, 0 score. 40 to 49, less than 40, 0 score. 40 to 49, 1 point. 50 to 59, 2 points, and more than 60, 3 points. The next question is, are you a man or a woman? So female gender, 0 score, male gender 1. And if you are a woman, have you ever been diagnosed gestational diabetes? So anybody who has been diagnosed of having raised blood sugars during pregnancy or a gestational diabetes, it is advisable that post delivery 4 to 12 weeks later they should be further evaluated, and if every evaluation is normal, then they should be on a follow-up every year to rule out whether they are developing diabetes or not. So if there has been a history of gestational diabetes, then the person gets a score 1. Family member, father or mother, if they are having diabetes, you get a score 1. And somebody with a high blood pressure, score is 1. How physically active? Are you physically active or not? If no, then score 1. And what is your weight category? So according to the BMI, the categories has been provided, normal weight, overweight and obesity. So we have to put the score. Anything that turns up more than 5, then that person probably needs to go to the doctor and get himself or herself tested to identify whether they are diabetic or not. So the criteria we know, when do we suspect, even in a young person, this performer can be filled, and with this score we can probably screen them early. As part of treatment, the only change which was, initially we were in a step ladder pattern of giving drugs. So first we'll plan to give one drug, then if there is no response, then you add a second drug. Nowadays it is treat fast and at the earliest, hit hard on the first go. That is what is the new change that we have in our management. The next thing is dyslipidemia. Diabetes, dyslipidemia, hypertension, obesity, NAFLD. They all are hand in hand. They probably 5 fingers of a hand. They go together. They won't leave. One is there, you will have the other. So the next thing which we can talk about is dyslipidemia. Why in the Indian context there is a difference in dyslipidemia among Indians and our European or the Western counterparts? It is said that we developed dyslipidemia a decade earlier than them. The risk factors or the morbidity or diseases like heart attack or ACVD, we have them early, we have them worse, and there is more mortality. So we develop the disease early, we die early. So the traditional risk factors, risk assessment scores like ACVD score or the JBS score, they all are, they take one factor as your age. So in that, if we put age, we are at a younger age, we are at more risk. So there has been a new guideline which is developed by the Lipid Association of India. They say that in treatment of diabetes, since Indians develop the disease early, so early testing should be done. You start evaluating the person early, and the treatment targets are a bit different. For example, in dyslipidemia with no risk factors, then first intervention is lifestyle. Irrespective of which category you fall, the intervention is lifestyle modification. That has to be done for all. If a low risk category person, then after lifestyle intervention, 3 months later you can repeat the test and see. If there is no improvement, then you add a low intensity statin. That is the first drug which we add to reduce the LDL levels. So by dyslipidemia, I mean to say that an LDL is elevated more than 100 and a triglyceride is more than 150. So this is dyslipidemia, and our targets are to reduce it and to bring it to normal. When do we want to treat? In a low risk and a moderate risk, lifestyle intervention is the first, but for a moderate risk person, we do add low intensity statins on the first go, and then you monitor the person 3 months later and check whether the levels have come down. What do you mean by low intensity? Low intensity does not mean the dosage of the drug. It just means to say that when you provide that amount of drug, then your expected target of fall of LDL should be around 30%. When you say moderate intensity, the fall is 30 to 49%, and high intensity statin treatment means that you want the LDL to fall from the baseline to more than 50%. That is the meaning of low intensity, high intensity and moderate intensity statin treatment. So how do we, there are various risk categories. For them, we need to know what are the risk factors. The most important is the major ACVD risk factor. For that, a man more than age of 45 years, a woman more than age of 55 years, that is a major ACVD risk factor. Somebody who is smoking or tobacco chewing, that is a major risk factor. Then high blood pressures and somebody with a low HDL level. The HDL level less than 40 in man and less than 50 in female is said to be abnormal. So any of these along with any high risk features, I am not going to read down because it will take a lot of time and it will become monotonous. So what I want to tell is that in the moderate risk, you hardly have one or no major risk factors with a LDL value which is more than 100 but less than 130, and non-HDL values between 130 to 159. The lifetime CVD risk factor is less than 30%. As you go to the higher risk, you will find that the ACVD risk factors keep increasing. So 0 to 1 is low, more than 2 is moderate, more than 3 along with end organ involvement or in the form of a kidney damage, or ACVDs in the form of a cerebrovascular accident, an MI, a peripheral arterial disease, even a non-obstructive thrombus which is present, obstructive arterial disease is also taken, and a peripheral arterial disease is also part of CVD. So in the extreme risk, what I want to highlight is that there is category A and category B. In category A, they are taking the coronary calcium scores also, which is more than 300. Category B, exactly the same thing, high risk with polyvascular disease. What is category C? This category C is important. It is those people who are on lifestyle intervention, maximum possible dose of statins, and on treatment, but with an LDL value less than 30 but still having recurrent ACVDs. Despite all proper treatments and the LDL value less than 30 as target, still they are having repeated episodes of ACVDs, then they are termed to be category C. And in category C, the treatment, the newer LI guidelines or the Lipid Association guidelines says that you lower down the LDL to 10, up to 10 to 15. Till now we were saying 30, but in recurrent ACVDs, we are wanting that the target should be even lower to bring it down to 10. As I mentioned, whom to treat? You have to treat everybody depending upon the risk. Lifestyle intervention is panned to all the groups. It has to be done for everybody. So there has to be a change in the diet. There has to be a change in the physical activity. As sir very rightly said, that 150 minutes of physical activity in a week. How do you tell? Because in busy schedule, if you tell a person that you have to do 150 minutes of exercise in a week, then it becomes a big burden for them. You tell them 30 minutes a day, that is also not possible for many because nobody has time. So you can say that you divide those 30 minutes over the day. It can be a 10-minute exercise in the morning, in the afternoon, or in the night, or you can divide at 15 and 15. But you have to do an exercise. And what do you mean by moderate intensity? The next question is, the person will ask you, what do you mean by moderate intensity? You can tell that when you do that exercise, by the time you start 5 minutes into the exercise, your heart rate increases, there is sweating, and you can feel the increase of your heart rate. You can talk to the person next to you, but you cannot sing. आप बात कर सकते हैं, आप गुनगुना नहीं सकते हैं. So that should be the pace of your exercise. So that is what is moderate intensity exercise. What other way of telling? You can jog, you can cycle, you can swim, depending upon the person's preference. So that is how you have to incorporate the moderate intensity exercise in daily. So that is one thing that you have to do, lifestyle intervention. Dietary, as sir mentioned, that carbohydrate reduction, total fat intake less than 30, and of that saturated fat should be less than 10%. So that is one thing that we should remember. And increase in fiber and seeds, that can be done. Then in the modern perspective, how we go about is, after lifestyle intervention in low risk, 3 months ke baad, you just again check the lipid levels. If the LDL is still more than 100, then you add this LIS and MIS means low intensity statin and moderate intensity statin. Your target is bring the LDL down to 100, less than 100. And in a moderate risk group, you start lifestyle intervention and low dose and moderate intensity statins initially, and after 3 months, if there is no improvement, you increase the dose of the statin and add a second drug, estimib, or accordingly. Then again the target is 70. Here in very high risk groups, you don't wait for a lifestyle intervention, you start statin at the earliest. What is important is, if a diabetic, your target for LDL is 70. If the person is having an end organ damage, it is 30. If the person has had a ACVD, for example, a coronary event, your target is 30. And if the person, despite all these measures and a good lifestyle intervention, still is having recurrent ACVD, then your target is to bring it down to 10 to 15. So that is how you escalate the dose of dyslipidemic drugs, antilipidemic drugs, sorry. So if we look at the targets, extreme category, the same thing which I mentioned. Okay. Sir mentioned about non-alcoholic fatty liver disease. Now the new name is metabolic dysfunction associated steatotic liver disease. It's a new name. Why? There was a stigma associated with it, fatty. So that has been changed. And the name non-alcoholic. So whom do you call alcoholic? Somebody who goes to a party once in a year, has a glass of, has a drink, doesn't mean that he is alcoholic. So should he be an absolute teetotaler? Do we mean to say that? No. So the definition, the name was changed, and the definition says that there has to be a hepatic steatosis or fat accumulation in the liver of more than 5% with at least one cardiometabolic risk factor. I will tell which risk factors we are talking, and with no other underlying cause. It means it should not, the steatotic disease or the liver disease should not be because of any infection or an autoimmune condition, and no alcohol or minimal alcohol intake. What do you mean by minimal? Less than 20 grams per day in a woman up to 10 years, over 10 years, and less than 30 gram per day for males. And what contributes to your MASLD? Your environment and your genetics. Both of them will contribute to your MASLD. And if a person is having MASLD, then the first degree relatives are also at a higher risk of developing metabolic associated liver disease. Then, as I already mentioned, formerly it was called as NAFLD. The cardiometabolic risk factors which we are saying is excess adiposity, BMI more than 25, but for Asians the cutoff for BMI is 23. So if by this standard we go, probably most of us will be overweight. Okay. Then central obesity, we look at the South Asian population, more than 90 centimeters in men and 80 centimeter in women. The slight differences in Japanese, the waist circumference is a bit higher for women and as compared to man. Man it is 85 centimeters and women it is 90 centimeters. And glucose, other metabolic disorder is a glucose metabolism abnormality, that is either a pre-diabetes or a diabetic person, or a fasting triglyceride level more than 150, your high density lipoprotein levels less than 40 and less than 50, and a arterial blood hypertensive person who's controlled on treatment or not taking treatment. So any one of these is a cardiometabolic risk factor. How do you manage? Lifestyle modification. For every metabolic disorder, the one thing which is sure is lifestyle modification. What do you want the person to do? Lose weight. How much? 5 to 7% from the baseline. Whatever his weight was, you lose 5 to 7%. The moment you tell weight loss, the patient will be like, ye kaise karna hai? So they are vexed. The moment you tell them, then they find it as an uphill task. Ki gaining is easy, losing becomes a bit difficult. So kitni jaldi karna hai? How fast should I do it? So you can tell them it is a slow pace, half a kg to 1 kg per week is sufficient. That means that 1 to 2 kilo in a month is sufficient. So it can be a very slow but steady weight loss that has to be advised. Then abstinence from alcohol. No moderation, abstinence from alcohol. Nahi pina hai. And drug therapy, there are many drugs which are given. Vitamin E capsules are provided. Resmetirom is a new drug that has come up for, it is a costly drug, it has come up for MASLD. Then ursodeoxycholic acid, many anti-diabetic drugs like GLP agonists, tirzepatide and many others in the pipeline have shown to cause weight loss, have shown to improve the steatosis. Then the next thing is obesity. BMI more than 23. It is a repetition because metabolic disorders go hand in hand. They are finger in a glove. They go together. So why important? Because more than 1 billion people in the world are affected. Why is it happening? Sedentary lifestyle, overnutrition. And it is not nutrition, it is just empty calories that we are chucking down. And socioeconomic status along with our environment and genetics. So that environment and genetics will add along with our habits. Association, again, obesity is associated with inflammation. Inflammation caused by adipokines and cytokines. What do they cause? Inflammation will affect the vessel wall. It will lead to insulin resistance. It will cause hypertension. It will lead to dyslipidemia and abnormal gut microbiota, ultimately leading into a kidney disease, the micro or the macrovascular complications of diabetes, and most important, malignancy also. What do? Exercise. Moderate intensity exercise is what you can advise. One important reason why we tell them to do exercise along with the moderate intensity, as sir mentioned, strength training is important, because as you start losing weight with fat, you lose muscle. So sarcopenia is part and parcel of diabetes and all other metabolic disorders, and the more you lose muscle, the more damage you have. And if a muscle is built, that helps to maintain the basal metabolic rate. So it also helps to maintain the weight. If somebody is doing exercise only aerobic, your muscle mass is not going to increase. You're probably going to reduce the fat mass, but you're not going to increase the muscle mass. So you will find it difficult to maintain. Then one metabolic disorder which I would like to say is gout. Why gout? It is a chronic inflammatory arthritis. As I've mentioned, the global burden is very high, and it is also associated with metabolic disorders. So uric acid levels start rising in obesity, it rises in hypertension, and in diabetes also. So gout is part and parcel of a chronic metabolic syndrome, and it also adds on to the inflammation associated with these diseases. So gout is another metabolic disorder which needs to be controlled, and there are risk factors which are modifiable, which are within our hands, and as we mentioned, the same thing which we said earlier: diabetes, hypertension, your obesity, alcohol intake, kidney diseases are dietary factors. You're eating a very high purine diet very rich in protein like red meat, so that can add to it. The things which we cannot change is age, gender and ethnicity, but the list which we can change is bigger. So on the positive side, whatever is in our control, we can change that. So what should we do? Treatment: acute manifestation is a severe joint pain, generally monoarticular, one joint involvement, classically the first metatarsophalangeal joint or the great toe involvement, called as podagra. The joint will be acutely inflamed, very painful, and the peak of the pain will be by 12 to 24 hours, the patient will have severe pain. You can't even touch it, so it will be that painful. Treatment is: for acute symptoms, you give an NSAID for painkiller. There are treatments like colchicine as well as steroids can also be used when your NSAIDs are contraindicated, but particularly in kidney diseases. But should you give a uric acid lowering drug? So it can be given if there are more than 2 gout flares in a year. So then a urate lowering therapy has to be given, and if there are deposition of the monosodium urate crystals, sometimes you can see it along the joint. The tophi will be deposited, white chalky, projecting onto the skin. So you can see there will be a bit deformity present. They can be sometimes it can be polyarticular. All of a sudden, many joints can involve. In such a scenario, you can give. And if there is only one event of gout in a year, but the person is having a kidney disease, or there are stone formation present, or if the urate level is more than 9, then you have to give. The only difference which I like to say is that gout is generally seen in men. Men are more affected. Why? Because of the protective effect of estrogen. It helps in the excretion of the uric acid better. So that is the only thing that is protective for women. Premenopausal age group is protective for women. As menopause occurs, then the risk factors and the severity is exactly the same as men.